Thank you very much. Hi, it's such a pleasure to be here. Good morning. We've got also a very exciting panel to rival Joe's excitement on key requirements and their phasing. Our clicker is not working, so I'm just gonna give cues and point. So this is kind of how we plan to address the session with each person giving their talk, and then we're going to try to leave 30 minutes at the end for discussion. And these are just the questions in the agenda that we're going to try to address, the key requirements. Okay, so back to our visual. I'm a very visual person. So as you can see, there's so many elements that we need to consider in the design of a scheduling system. There's a lot of variation in the needs and capabilities of patients. There's variation in providers, in their own schedules, and the services that we offer. And we're trying to keep this all in mind and match the patient side to the services and provider side. The best scheduling system is one that can match the patient need for appointments to the right provider with minimal delay. And to me, the word access encompasses a lot of meanings, but first and foremost, it's the delay for patients to be seen. And when we improve access, we're reducing the delay for patients. Continuity is guiding the scheduling system to the right provider. And in primary care, the right provider is the patient's PCP. In specialty care, when a patient requires follow-up, the right provider is to get them to the provider that they've seen before. Because of technology and data, and as we've heard, there's really so many features that we could consider to build a state-of-the-art system. But there are some foundational elements that must be included in the initial state. So if we simplify the picture like this, we're trying to get the right patient at the right time to the right provider. And most of these foundational elements I'm going to go over, they're really quite basic, but I've seen that it's really common that people skip over them, or they think they're so easy that they get them just a little bit wrong, where it creates problems later on. So I want to make sure that we don't skip over them in this very important design discussion. Okay, one of the basics, we need the scheduling system to be able to answer in primary care, who is the patient's PCP? When we know that, we can program the scheduling system to first search for availability with the PCP before looking for a visit that would result in discontinuity. And the PCP is a super common field. All the EMRs have it, yet I've seen a lot that it can be ignored or inaccurate when making this link between the two, so it's crucial to keep it up to date, and the scheduling system should be dependent on it because we want that continuity. It is also important to have some controls in place as to when or how the PCP field can be changed. And that's because every provider has a limit on the number of patients that they can manage in their panel. And if they reach that limit, the scheduling system needs to reflect that and close them to accepting new patients. If the PCP becomes responsible for too many patients, we're going to get a system designed for discontinuity or delays, and that's exactly the opposite of what we're trying to do. Therefore, we need a scheduling system that can answer, can this provider accept more patients? And although this concept kind of takes place outside of the scheduling system itself, we need to determine what is the panel limit for each provider, and the scheduling system needs to know what that is. Balancing supply and demand at that panel level is a key to managing delay and to ensuring a smooth scheduling process flow. So we would need the following data from the scheduling system. One more, thanks. Okay, how many patients can each PCP manage? And then how many visits do their patients generate? This is the panel demand. And we would compare that to how many visits can the PCP actually see? And that's their supply or capacity of the provider. And that's usually determined by how many days do they work and how many patients can they see per day. So when demand is less than or equal to supply, then the provider can accept new patients onto their panel. And otherwise, the provider should be closed to accepting more patients until they're balanced. And it's important to monitor this panel balance regularly. We want a scheduling system that can provide this data. And also, when a new patient is seeking to establish care, we want the system to be smart enough to know who's at their limit, who's not, and only search for availability with the provider that can accept more patients onto their panel at that time. We have to eliminate the need for manual checking outside sources. We want that integration that we talked about yesterday, where the scheduling system knows how to direct the patient and make it easy for the scheduler or the system itself to do the right thing. Another basic, most obvious question we need the scheduling system to answer is, when is the next available appointment with the PCP? And we don't want that answer to depend on, imagine you're a scheduler and you have kind of a blank slate and you're selecting all of this search criteria, possibly from hundreds of options. When we design a system in that way, we're always going to get a different answer, so we need to make it as simple as possible. And how do these hundreds of options maybe happen? There's lots of ways, but one example is sometimes a provider's supply is segmented into different sections. And you can click again, thanks. And it's either maybe because of differences in physical location where they're seeing patients, or even in function. And there's lots of different functions, but as this example I'm at a clinic seeing my patients versus I'm at the same clinic, but I'm supervising residents who see my patients. And that's just one example. But as much as possible, when we're designing those grids or templates in the scheduling system that say when and where a provider is working, we want to minimize these segments of supply. And it sounds like the VA is well aware of that, as we heard yesterday with the stop codes and the only seeing PTSD patients in this section. We're trying to totally minimize that and have one grid as much as possible. So when it is necessary to designate supply separately within one provider, sometimes you might encounter some situations. It's essential that the scheduling system is going to be able to search across all grids or templates to which that provider belongs. And this should be the default. So for example, the patient needs a visit and the EMR is telling us that their PCP is Dr. A. So we would want the scheduling system to know automatically, pull in Dr. A at location 1, Dr. A at location 2, and Dr. A supervising residents at location 2. If these are all of their segments of supply, pull all of that in so we can find the first next available appointment with Dr. A. The manual process of selecting multiple grids, it's really cumbersome, fraught with error, and we want to do away with that. So automating the selection of the templates or grids to search across with wider as the default and being able to narrow down if necessary is really the best option to find the first next available with the PCP. Many of the fundamentals that I'm discussing here in primary care also apply to specialty care. There are some slight differences. So in primary care, the PCP has a panel of patients, and the appointments of that panel should really be viewed as one queue to the PCP. And one indication that there might not be a single queue system is if there's different weights for different types of patients. So, for example, for most patients, the next availability is tomorrow. But for annual exams, they have to wait 3 weeks. We want to eliminate these rules as much as possible in the different amounts of waiting. And really, by designing a system that has that view of the one queue of patients to their PCP is going to help us do that. And minimizing the rules will be reducing queues and eliminating the need for all that inclusion and exclusion criteria and the different weights across patients. Now, because we want to direct all patients to their PCP as much as possible, we're really viewing this as each PCP has a single queue of their own patients to them. For appointments that have to wait because of physiology, they were just seen, they're going to schedule a follow-up visit, we want to make sure we allow the scheduling system to schedule those in advance. I've seen scheduling systems that only allow you to schedule out 3 weeks. We don't want to design a system like that. But if an appointment does not have to wait, like for physiology, then we just want to be able to offer the first next available. Also, some primary care systems have been designed where basically all of the patients are in one big queue, and they all lead to all of the providers at that office, and patients just get distributed to the first next available without a focus on continuity. We don't want to design a system like that either, because one of our primary goals is continuity. So that's why each PCP has their own queue of their patients. So in specialty care, patients often have more of a consultation relationship. They may be seen more than once, but overall the specialist is not taking responsibility for the overall health of the patient like they do in primary care, although there might be a long-term relationship established if there is an identified need for the specialty. But each specialist has a caseload of their own patients, and their follow-up appointments or return appointments, they function just like we were talking about in primary care, where their patients should be following up to them. They have their own queue of their patients. But the difference with specialty care is that there really needs to be a separate queue for new patients, and this should be one queue of new that gets distributed to the first next available across all of the specialists, and that's because they don't have that relationship established yet. So to ensure that new patients don't have to wait and go to the end of the line, like we see with returns that, you know, I saw you today, follow up with me in 3 months, the returns have to wait. We don't want news to have to wait 3 months and go to the end of the line. So we have to carve out space for them in the schedule. And this is creating a separate queue just for new patients. When scheduling a new visit, the scheduling system needs to know to automatically search across all of the providers, all of the specialists, all of their grids, and we have to remove the manual steps of adding providers to the search pool. We want to start wide and narrow down if necessary. Now, the risk of creating multiple queues, I'll say, is that it's impossible to get it 100% perfect. On guessing how much space you need for one versus the other. And so that's why we typically discourage more queues, except in specialty care, there should be 2. And that's because there are more returns than new, and they get to the schedule first. So the returns are going to squeeze out the room for new unless we're saving space for them. Now, when we're creating multiple queues, when you get this wrong, you might either have too few slots and that results in delay, or you might have too many slots and that could result in unused provider time. But with data, we can at least get close, and I think we've seen lots of sophisticated ways to use data that we're just going to keep getting better and better. All right. Also, for specialty care, it's not uncommon that a patient sees a specialist and then they get labs or tests ordered and they get those done and then they go back for follow-up with their specialist again. But there is some opportunity in primary care to send the patients with these things already at least ordered, if not completed, so that we have more value at that first visit. So it can reduce the longitudinal time from the consult need identified until the care plan is actually established. But also, if it results in some cases where the patient needs to be seen once instead of twice, or twice instead of 3 times, we're really streamlining demand for specialty. And it's not the only thing, but it is something that can help to minimize delays for all patients. And we care about this from a scheduling perspective because in most systems, patients can be scheduled with a specialist without that proper preparation. They might need a referral, but that's about it. So we could actually try to build some of this preparation into the scheduling workflow. So for example, when a primary care creates a referral, there could be a checklist for how to properly prepare that patient with a specific condition. And if primary care does not complete that checklist to order specific things or provide pertinent information, then it just would not electronically send. And if the proper orders are in place, this actually helps scheduling too, because they can see what's ordered and try to sequence those tests or labs ahead of the visit. And we heard about that in some of the examples with the VA yesterday. This concept is often referred to as service agreements. I know the VA is no stranger to these, but it's really where the specialists are defining how to properly prepare the patient, and then primary care is agreeing to send them that way, especially if it's helping their patients to be seen right away. And in terms of phasing, implementation of the service agreements, it's often best to just start with some really basic, well-known conditions, start with those, and you can continue to expand and add on your list from there. But it's really about embedding the checklist into the referral. Thanks. All right, so I'll leave you with this summary, that our goals for the scheduling system are to minimize the delay and maximize continuity. We need the scheduling system to be able to answer some basic questions. Who is the patient's PCP or specialist? Can this provider accept more patients? When is the next available appointment? And how do we send patients that are perfectly prepared to specialty? And for our system design, again, we want to make sure that we're trying to design a single queue system for primary care and 2 queue system of new and return to specialty. We're trying to minimize queues, so minimize all of those appointment types and segmenting of supply as much as possible. Simplicity will be your friend, and you will be able to build on top of that better than making things very complicated. And it will also help with the whole scheduling process because we're reducing that manual search criteria. So those are our goals, and next I'm going to hand it off to Ava.